Hey, I'm Di McQueen, licensed clinical social worker, family and addiction expert. I'm here with Dr. Brian Jackson, my longtime cohort who specializes in the field of addiction. Welcome to Healing Families Shattered by Addiction.
Di and I have worked with addicts, alcoholics, and their families for over 30 years combined. Our podcast and coaching programs focus on families who have a loved one suffering from addiction. Our experience has been that this disease affects families as much, if not more, than the addict or alcoholic.
Is your world spinning out of control? Are you codependent? Are you experiencing worry, loss of sleep, and difficulty concentrating? If so, you're in the right place. Brian and I have both personally lived it, learned it, and now we're going to teach you tools and techniques on how to get your life back that you thought was shattered by addiction. When addiction feels overwhelming, the right support can change everything. Recovery Keys, located in Ponte Vedra Beach, offers accredited residential and outpatient treatment for substance use and co-occurring mental health conditions. Unlock the keys to your recovery today. Visit recoverykeys.org or call 904-551-1394.
Okay, let's dive in. Hi, everybody. Welcome to Healing Families Shattered by Addiction. I'm Dr. Brian Jackson. I am here with my partner, Diane McQueen, licensed clinical social worker, master's level certified addiction professional, and an advanced accelerated resolution therapist. And we welcome you here today to our show, and we are really pleased to have a guest, because when we have a guest, it takes a lot of pressure off us, right, Doc?
No. You got it. Yay. Thanks, Jason.
Not a problem.
And as you all know, we from week to week, every other week we do a pod. Sometimes we have guest speakers. Sometimes it's Ty and myself. Sometimes we have an attorney, but we're fortunate today to have a doctor of addiction medicine with us here, Dr. Jeremy Hunt, or Jason Hunt. I'm thinking of Jeremy, your boss. Dr. Jason Hunt.
And Jeremy's my brother too, so you're not too far off.
Okay. But in any event, Dr. Hunt is basically head of all the clinical work that's done at Recovery Keys, who is our sponsor. And so it's nice that the staff is able to make themselves available to us to tell us a little bit about Recovery Keys, and then also how addiction relates not only to the individual but to the family, because they do have a family therapy program over there, which, as you all know, is our quote unquote area of expertise in terms of dealing with families who have a loved one that's suffering from addiction. So welcome, Dr. Hunt.
Glad to be here.
So
welcome.
Anyhow, so maybe, I know a lot, or not a lot, but quite a bit about your bio in terms of places you worked, what you used to do. But maybe you can tell us why you got interested in addiction medicine. I think a lot of people don't understand that, you can be a physician, but you can't choose just to be an addiction medicine doctor. There's some education, training, and certification that goes along with that so that you can practice addiction medicine. So if you wouldn't mind taking us through a little bit of that, that would be really helpful. Thanks.
Sure. Thanks, Dr. Jackson. And Di, it's good to be here. Yeah. Again, I'm Dr. Hunt, originally from Kentucky. So if you need an interpreter for the accent, I apologize. But I grew up in Murray, Kentucky, with the undergrad at Murray State University, did my medical school at the University of Illinois. I actually did a OBGYN residency initially at the University of Louisville. And I did that because my mother and I had come from a family of addiction, mental health issues, but my mother died of ovarian cancer. So that was the reason I actually went into OB, as well as how the birth of my daughter really kind of turned my life around. I'm in long-term recovery as well, and chose OB because I wanted to go back and treat women with cancer and then deliver babies to help change their lives. As I was practicing in Kentucky and then in Alabama, it was in the height of the opioid crisis. And I will mention that psychiatry and addiction was kind of a second love of mine, even in medical school. But I went ahead and chose OB first. And now in the early 2000s and up to 2010 with the opioid crisis, especially in Alabama and Kentucky, had a lot of patients, especially pregnant patients, obviously, and that's probably the most stigmatized patient population on the planet. Now, addiction itself, as we know, is the number one stigmatized medical condition, but a pregnant mother with addiction is even more so. So I had so many patients suffering with this disease and this illness that I wanted to learn more about it. So I actually took a addiction medicine fellowship with the University of Florida in their psychiatry department. I completed a 2-year fellowship with the plans to return to rural Alabama, even maybe rural Kentucky, back into my home state, and treat addicted pregnant women and pregnant women with mental health issues. After the fellowship, I was offered a faculty position at the University of Florida in their psychiatry department to treat addiction. So I stayed there for 9 years. I was able to still treat pregnant women. It was mainly more on a consultant basis, or maybe consulting on labor and delivery, or treating them with outpatient, especially with opiate use disorder and the new medications for opiate use disorder. And after about 9 years there, I had a great opportunity to join Dr. Marabli and his incredible staff and the facilities he's built over in the Ponte Vedra area. And it was very similar to what I experienced at UF. We had all levels of care from a residential treatment facility as well as a detox unit. And then we have outpatient PHP and IOP, which UF offered as well. And I really wanted to be in a place that offered full access of care, and it didn't hurt to it's over here on the beach in this beautiful area either.
Yes, you're roughing it pretty good at this point, right? No, it is. It's a beautiful facility. Yeah. You also have a family program there as well, don't you?
Yes, we have a very robust family program, and we really keep the families very involved. We have obviously a full-time family therapist that runs weekly groups to really educate them on many substances. I mean, on many subjects, from just from relapse to the disease model to boundaries, enabling behaviors, any different topics, individual things that they may be going through, and that's offered every week. Plus, we try to set up weekly inpatient on-site visits with the family as well. And if they can't be reached by if they can't come in for an in-person visit with our therapist, and even when they come in for those, the doctors usually set in as well as the patient's primary therapist. So we really involve the therapy, and we've really been fortunate in this area to have a lot of family involvement. You don't really see that in addiction a lot. Sometimes by the time they enter treatment, we know they've entered at the latest stages when the disease is more acute, when it's harder to treat, when it's more expensive to treat, where it takes much more to treat, and they might have lost that family support. And so we feel blessed that we do get a lot of family support, and we utilize that as well.
Yeah,
Yes,
I think. Go ahead, B.
Yeah, so I think it's real important what you hit on there too, is that I think there's a misnomer out there that people go to inpatient treatment because they have a alcohol use disorder, a substance use disorder, and that's what's being treated, right? So you're locked up for 28 days, 30 days, 60 days, 90 days, and all your choices are taken away from you. But you touched on, the piece that's very, very important, and the pieces that we really like about Recovery Keys is that the dual diagnosis portion of the disease is addressed. And when I say dual diagnosis, I don't mean to dummy this down too much for the audience out there, but a lot of times people are self-medicating with drugs and alcohol. Some other problem that is typically some sort of psychological behavior, it could be trauma, depression, anxiety. And once that medication that they're taking to self-medicate becomes a problem bigger than the problem that they're trying to manage, that is really where the work, I think, is done. Dr. Hunt, you can talk about that, since the psychiatric background that you have. Is that what you're kind of seeing, like after you put some time and distance between the last use, like really what's coming to the surface, like what is going on that needs to be addressed so that the rate of recidivism can be diminished, as opposed to just, okay, you stop drinking, goodbye, have a nice day?
Yes, and actually, you're right. A lot of times you might hear in the rooms of AA or NA or other support, mutual health, self-help, 12-step groups talking about how the alcohol is kind of the symptom, not the underlying cause. And it's so especially what we're realizing now with early childhood trauma and measured with adverse childhood events or ACE scores, how it's really a mental health disorder, a mental health disease, addiction's a disease, but almost all will have some level of trauma, and everybody's trauma is different, right? In our childhood, some may respond much more resilient to a trauma they go through versus somebody else. But that's the one thing we always refer to addiction as a disease, but the one thing different, even though it's highly genetic, it's 50% environmental, 50% genetic, it's chronic, but almost always there's this underlying trauma that it may not be the cause of the addiction, but if it's there, it will definitely bring it out. And you did mention on something about how I talked about how it's similar to other diseases, and when we look at outcomes, it's also very similar because a lot of people think treatment don't work or they've been to treatment multiple times. And we don't say that with other chronic diseases that the problem is treatment doesn't work. The problem is we've kind of built this system where we act as if we can send somebody away for 28 or 30 days, fix them in one short intensive episode, send them home, and then if they relapse or return to use, we blame the patient instead of the design. We would never do that with other chronic diseases. We don't give somebody with diabetes 30 days of insulin and then say, you're cured, good luck. We don't give someone with hypertension a month of medicines and a bunch of blood pressure medicines and then act shocked when their blood pressure climbs back up after we stop everything. Addiction behaves similar to these diseases as well, and it needs ongoing management, not one and done episodes. So it's kind of the way we built this system, and we need to treat it as this chronic care model where they're getting lifelong treatment, and the disease can be put in remission. Addiction can, we talked a lot about the devastation we see in addiction, the opioid crisis, the overdose deaths, but we don't talk enough about with good, adequate long-term treatment, most people do get better. Treatment does work.
Right. And I love what you just said, which is, Brian and I used to thump our hands all the time when we ran the treatment centers going, you need to give us some time to stabilize this person. We'd get 10 days or some crazy amount of time, which was, like the person hasn't even come to yet. And I love how you tie it in with, the longevity of, and it looks to me like the outcomes come out so much better if we can do some step downs, but also for the family, so that there's a lot of explanation as to how they also understand the model of disease, right? And you guys do a nice job of being able to explain to them, because I still get it. After all the years in this business and after all of those things that we keep trying to work on, I still have family members come in here and go, just get over it. Like, I'm sick of this. Why don't they just get over it? And, you can explain to them, and then you finally start to educate. And a lot of them have never been educated on the disease of addiction. So you agreed?
I do agree. And if we start to accept addiction as a chronic, treatable medical illness or a brain disease, if you will, it changes our practice. It changes how the healthcare system sees patients. It changes how family members see patients, right? If we stop treating, we mentioned relapse before, if we stop treating relapse or return to use as a moral failure and start treating it as a sign that illness needs more or different care, if we stop using shame as a clinical tool and start using evidence-based medicines, therapies, and long-term follow-up, then we're going to see much more improvement, a much more understanding, a much more compassion. And if we do understand addiction as a chronic treatable brain disease, we will treat our patients different. Family will see their patients different. We'll recognize relapse as part of the illness, not proof of failure. And we'll talk to people with less blame and more respect. And we'll advocate for systems that fund long-term care instead of short-term crisis management.
Exactly.
Yeah, Dr. Hunt, you talked on trauma, and Di, as my partner, has taught me a lot about trauma, and trauma can come in all shapes and sizes. And I consider Di an expert on adult children of alcoholics, and she's also an advanced accelerated resolution therapist, which is you're dealing with trauma where you lose, you keep the facts, but you lose the emotion associated with it. So Di, I'm kind of put you on the spot. because, you've taught me a lot about how trauma is a big part of this, separate and apart from the drinking and the drugging. Do you mind chatting about that a little bit?
No, I love it. I love it because I think that's where it all begins and ends, right? I mean, I think we talk a lot about emotional sobriety, right? When you get rid of whatever we're trying to self-medicate underneath there. And I think, Jason, you sort of, or Dr. Hunt, you sort of touched on that as well, which is there's all these stats that we now start to understand. Typically, there is an event of some kind, whether or not it's something that we call a big T or a little t event. The big T's are very easily recognizable, right? When you've been raped or you were held up at gunpoint or something traumatic that you can identify happened. But for me, I go way in there with the what I call the little T's, right? Those comments that are over and over again, or neglect, or the things that we had, very simple things, being compared to brothers and sisters, or being told you weren't pretty over and over again, or judgments that were just so strong and violating perfectionism, where that all comes from and the understanding of it, and how the family system also feeds into that is quite interesting, at least from my experience. And I'd be interested in hearing if you see the same thing, because a lot of times we replay those scripts over and over again in our lives. And, we continue to get that sort of uh, re re certification of this terrible trauma over and over and again without even knowing that we're doing that to ourselves, because it's very familiar. And so if I have been a person who was shame based, which is where I came from, I found people and sought people out that were also shame based, which also kept me in my addiction for a long time, right? Until I started understanding that is not a helpful tool and I need to do something different. And I also spend a lot of time, I know you do now too, B, and I think you guys do as well, teaching family members how to dance a different way, how we change this dance, right? You guys did this. So we sit down with both parties and help them explore why the behaviors that they choose to use and the way that they sort of interact with one another and the communications they use are not necessarily helpful in each other's recovery. Thoughts about that?
No, I mean, I love that approach, and I'd like to just kind of go back and talk a little bit about kind of just briefly when we talk about the stigma, some of addiction, and I'm going to tie in some trauma and some other things that to help us help these patients. Right? It's kind of like, so it's like, what is addiction really? Right? What is it? You hear all these things. Is it a choice? Is it a weakness? Is it a physiologic dependence? Is it a learning disorder or a lack of willpower? You might even hear it's an amoral condition or a sin. Right? And those are all narratives that you will hear, or families will hear, or people will hear around the dinner table. You'll hear in churches, you'll hear in courtrooms, sometimes even in clinics, but they all miss that main point. Addiction is fundamentally a brain disease, which I can't emphasize enough, right? And decades of neuroscience have shown us that addiction is a chronic brain disease. And not only that, it changes the brain, especially in those circuits involved in reward, stress, and self control. And some of those vulnerabilities, like we said, have been there even before their first drink. And that's where the trauma ties in, right? The trauma has already set the brain up. The changes in the brain are very similar to the changes that happen with addiction. And then they're just, it's pouring gasoline on a fire once you add the addiction to that underlying trauma that somebody's dealt with. And then you also tie in genetic risk. Again, I can't mention early trauma, big T, little t's, like you said, any other mental health condition. But repeated substance exposure pushes that susceptible brain into full-blown disease. It really does. So when we talk about addiction as a brain disease, I want to make this clear too, we're not erasing responsibility. We're saying that that framing doesn't excuse the behavior, but it gives us a realistic medical framework, especially addressing the trauma, on how to treat it.
Yeah,
Yeah,
so
it
I think
sounds
what I hear you saying, Dr. Hunt, is the brain's hijacked. It is a brain disease,
mm-hmm.
and we become powerless over it. But I think what you subtly said is we're basically not powerless over choice, right? So the person that's saying to the spouse, I'm going to stop, I'm going to stop, I'm going to stop, I'm going to stop, and they don't believe a word they're saying anymore. But when they say, hey, Brian, hey, Di, what do you think? Well, I think you need to have all your choices away from you. I think you need to get to recovery keys, get an evaluation, and all the rest. That's giving that's an outward sign of an inward change, right? So family members are watching that and going, wow, she's finally doing something about it. And that's the only way I think that there's any proof that there is some willingness. And I guess the best cases are where there is some willingness. I mean, you can go to the best addiction doctor, Dr. Hunt in the world, the best treatment facility or whatever, but if you don't have any willingness, it's not going to work. And back to it as a disease, I constantly say this, and I don't know, I don't mean to poo-poo it, but of all the diseases out there, I'll pick addiction. And the reason why, as opposed to cancer that can go into remission and through no fault of my own, it can come back, or my diabetes could get worse, or my hypertension could get worse. But if I do what's suggested by Recovery Keys, by PHP, by IOP, by Dimeclean, by Dr. Jackson, that continuum of care, that maintenance, I can keep this disease in remission. I mean, I have a part in it. No doctor is going to lay hands on me, operate on my brain, and remove, this compulsion to use. So I think that's sometimes people go, oh shit, I didn't think of that, and I think that, relapse, as you said, can be part of recovery. It doesn't have to be part of recovery. But as a counselor, we used to sit there in group when we had the IOP and say, you know what, if you go back out, it's going to be worse. Well, what the hell else is a counselor or doctor going to say, right? But then they go do it. And if they're fortunate enough to come back, some of them don't come back, they say, wow, that was bad. So now they've learned it for themselves. So anyhow, I'm getting in the weeds, but
no, I like it. And I want to touch on two things. I don't know if we do it back to back, but you talked about relapse and you said, relapse is definitely not a requirement, right? And and true relapse is very, very rare in addiction, right? It's actually less rare than relapse in hypertension, relapse in diabetes, relapse in asthma, because most people in addiction return to use. They have a recurrence of symptoms. They have a recurrence of signs. You have to be in full sustained remission to relapse. And that's a good solid year to 3 years of recovery. So most people's brains haven't healed to the level where they're in good recovery, full sustained remission, and then relapse. They're still in the midst of healing, and they have recurrence of signs and symptoms, stress, trauma, that they return to use. So that's really the medical term. We don't use relapse as much anymore. And it's good to say, because let's get back, to where addiction and relapse belongs, right? It's the same in those other chronic diseases as I mentioned, like diabetes, hypertension, asthma. Addiction follows patterns of relapse and remission, just like those do, right? And the relapse return to use rates are 40 to 60%, the same as all these other chronic diseases. And think about how we treat those other chronic diseases, right? A patient with diabetes is told what to eat, what medications to take, what lifestyle choices to make, and surprise, they don't do it all very well. We're not very good patients as human beings, right? So they might end up back in the hospital with hyperglycemia or DKA or other diabetic complications. And that patient with hypertension, same thing, right? Or heart disease, they may be not adherent to their medications or their diet, or not follow the doctor's recommendations and seek counseling, take medications, and go to therapy like's required, right? Just like addiction patients don't. And then they come back with higher blood pressure, or heaven forbid, a stroke or a heart attack. Someone with asthma misses their inhalers or doesn't fill their medicines or keeps smoking, and they have an asthma flare, right? We call that a relapse of the illness, right? We're worried, we're sad, we're frustrated, but we see them as patients and victims of a disease. We even practice harm reduction in all those cases. If a diabetic doesn't want to start insulin or is scared of needles, we will try oral medications, even though that's not the best course of action for them. If someone can't quit salt or adjust their diet, we'll adjust their blood pressure medications to accommodate and practice harm reduction. Now compare that to addiction, right? How would you respond to addiction? The relapse and return to use rate, I already told you, was identical. people with addiction also struggle with following recommendations, changing their lifestyle, taking medications, dealing with environmental stress, and they also have genetic predispositions. And on top of that, what we talked about earlier, that these other diseases don't have, they almost always have trauma. And trauma is a precursor to addiction. And it may not be the only cause, but for someone who's vulnerable, trauma can pull that disease forward. Yet this is the group we often shame. And instead of saying your disease flared up, let's adjust treatment, we say you failed, you're non-compliant, you don't want recovery enough. And that gap is stigma. And stigma is not just rude, it's deadly, because the power of stigma prevents these people from seeking help. And that's what we have to change.
100% agreed.
And speaking of stigma, which now I'm going in a different direction, I mean, obviously you prescribe medications for people with certain psychological issues. Di and I have a hard, fast rule that we stay away from putting labels on people because of stigma, right? So if you say somebody is bipolar, what we're finding is even though they get better, they have the stigma in their mind like, oh, I'm bipolar. Well, who told you that? And when did they tell you that? Did they tell you that like 2 days after your last drink or, whatever? Because, I mean, obviously depression, anxiety, psychological issues come in all shapes, sizes, and forms, and DSM-4 or 5 or whatever likes to put now all kinds of caveats onto these different diagnoses. But what I liked about what you said, Dr. Hunt, earlier was that, the dopamine reward system, the serotonin system, it's almost like throwing coffee on a laptop and trying to figure out why it's not working correctly, right? So now in your office comes Johnny, who is just coming in for treatment. He's coming in to meet Dr. Hunt. Dr. Hunt is going to assess what he needs to try and get him through this detox or whatever. I guess I'm trying to see what your philosophy is in terms of treating underlying behavioral health or mental health issues with medication-assisted treatment, and how to avoid, because I find that the stigma associated with mental health is twice as bad, if you will, for people associated with addiction. So anyhow, that's my question.
Well, I would say there is stigma associated with the medications with mental health, but I will have to admit that it's not even close to the stigma against medications for opioid use disorder or MAT. Now, we say MAT or medications assisted treatment, or we say medicines for opioid use disorder, or we say harm reduction, right? When people hear the word harm reduction, what do you think most people, even in our specialty, our field, our addiction medicine, our mental health, our counseling field think, or even the general public, when they hear harm reduction, what do they generally go to? Addiction treatment, right? Don't most people associate harm reduction with? Now, my argument is harm reduction is just medical treatment, right? Because we treat every single chronic medical disorder or disease with harm reduction and harm reduction strategies. What is the very first thing? I actually have it on my wall right there. The very first thing that doctors do in medical school, what are the first thing we say? We say, I solemnly swear to practice harm reduction. Now, I don't say it that way. I say, first, do no harm, the Hippocratic Oath, right? So people were trying to reduce that stigma as well. But as far as medications for mental health disorder, which is extremely stigmatizing without a doubt, or medications for addiction, I haven't seen a pharmacy yet refuse to fill a prescription for a mental health medication.
Right.
They will refuse medications all day long for MAT. Now they're getting better. Go back 10, 15 years. And it was big time stimulus. So, and you don't hear you're trading one drug for another when you're talking about antidepressants, anti-anxiety, antipsychotics, right? But you'll hear that with medications for opioid use disorder, which science has proven it's not. They act differently on the brain. Medications for opioid use disorder, longer acting. Now they're not a silver bullet. I wish, and I think one day we'll have medications that the brain doesn't become dependent on, that have to be weaned off. But we know through science and MRI and imaging and functional MRI that the brain, those pathways in addiction actually heal quicker on those medications than off it because you're reducing the stress of the midbrain, you're reducing the inflammation, you're reducing the stress that causes brain changes that lead to craving, relapse, compulsion, and all those other things. So on the surface, it may look like you're trading one drug for another, but the science backs up, and the evidence definitely backs up that you're not, because we see a 95% chance of reduction in overdoses in Europe and other places. Have been using these medications since the 90s, which is years and years before we started using them at the rate that we are. And we see a good 50 to 80% decrease and here as well. And as we start using these more and more, we'll even see greater improvements.
So so glad you said that, because I assume you're talking about buprenorphine or Suboxone. Is that correct?
Yes, sir.
Because a lot of families will look at it like switching chairs on the Titanic, or people who go to AA meetings or NA meetings. Why they feel like they have to disclose that they're on Suboxone is beyond me. Because if they were on a high blood pressure medicine, would you reveal that? And so they get judged. But if everybody heard the explanation that you just gave,
Mhm.
there's a reason. It's not just throwing a pill at somebody and just to go get on another equivalent of an opioid, and we'll titrate you off of that over a period of time, and it won't be as bad as the withdrawal symptoms you'll have if you just stop taking Oxycontin, banging heroin, or whatever. So I really appreciate that. I just learned something.
And kind of back to your evaluation, like you said, it's all case by case basis too. It's not everybody. When we see somebody that may have an opiate addiction, especially if it's fentanyl addiction these days,
Well,
that person may need this medication longer than somebody who's been just abusing their oxycodone. And we do evaluate it case by case. And it's, somebody said, well, how long do they have to be on it, doc? I'm like, well, how long do you have to be on your insulin? I don't know. Sometimes people get put on insulin. They go to treatment. They get their medicines right. They exercise. They diet. They come off insulin. Some people can do that with this medicine too. So it's like I said, it's not a silver bullet, and that's something we always address at almost every visit, depending on how well the recovery capital is going. Did they go to treatment? Are they going to meetings? Are they not involved with the criminal justice system? Do they have an education or going to school? Is their home life going well? That person could probably start to taper off sooner. Some people that's maybe been in treatment multiple times, multiple overdoses, and with fentanyl out there, that person may need to be on it substantially longer, or maybe even for their whole life. But that's not a decision we make at the beginning. We make that as treatment progresses. Some people can be on it a year, come off. Some people need to be on it much longer. So it's really case by case. It's not one size fits all. That's for sure.
Which is something I love hearing, because that's kind of been one of my arguments all along too, is that everybody is different, right? And each person, I mean, we see it all the time in our practice, right? Be where, we start to address some of the underlying conditions, and guess what? All of a sudden the person isn't feeling so depressed, and they've released so much stuff, and they start to, wean off of some of these meds, which, again, I always tell them, you need to be talking to not your medical doctor necessarily, who doesn't understand anything about addiction. You need to be talking to someone who does understand addictive disorders and can help guide you in a much better way than, someone just going, oh, it sounds good, I'll just write you a script for this. That's, I mean, I have a big pet peeve about that, because they need to understand what's actually going on within the person's brain. Half the time I'll ask them, have you ever had a conversation with them? Did they ever take a class in medical school? And the answer is often no. So that's a great thing that you just pointed out, and we see it, and each person is different, and I like that. Everybody has their own thumbprint, right? So we work it that way as well. We might try some general practices, but at the same time we have to make an assessment of the person to steer it that direction. I'm going to ask you to steer it a different direction, because I want to ask you, before we wrap up today, what are your thoughts about these synthetic drugs that are out there, the kratom, that those types of drugs that are sold in smoke shops? I know when I see people that have been using and abusing these types of drugs, it's really unbelievable, out of control. But we still have this problem with people who are just going, they can walk right in the door. And I've seen more psychotic behavior than any drugs that I've ever seen, real street drugs, fentanyls, but they're very scary to me. And I didn't know, how often do you guys see that? What is your assessment of that? And, is there anything that we can do as practitioners to help, with those situations?
Wow, it's a great question, and we're seeing it more and more, without a doubt. Now, I was living in Alabama before moving to Florida, and kratom was illegal in Alabama in 2014. And it's they supposedly just made it illegal here, but there's still people that say that they're still finding it on the shelves, and it's
Yeah.
becoming more and more potent. And I've seen so significant cases where the kratom has taken over their lives, just like fentanyl has taken over somebody else's. The withdrawal
Yeah.
is just as bad. They're needing just as bad detox, and they may even need medicines for opioid use disorder or MAT because it's so bad. And everybody's brain's different. That's why people have different drugs of choice, and there are just some people that this drug really hits home, and they become addicted very fast, and it can take them down just as fast as heroin, fentanyl, or any other medication or illicit drug, without a doubt. So it's becoming a big problem. We need a lot more education on it because people think they can just walk in and, oh, it's here, it's on a shelf in my convenience store. And we're also finding people that, you know, we actually see the people with an opiate addiction steering away from it more because they understand. But then you have other people that never had an opiate addiction that are hearing about it from friends, and then they seem to get addicted even quicker because their brain is more opiate naive, and I think it hits them even stronger, and it takes them down even faster, without a doubt.
Yeah, I definitely see that it's, some of these are real problem statements. I think some of the people we've seen, on bath salts and spice and things like that, I mean, just beyond. And it's so sad because they went in there just going, oh, I'm just buying this spice stuff.
It,
Thankfully, they did take that one off the shelf, so that's good.
yes.
But, it goes to the next and the next and the next. Yeah.
It,
So
Oh, I was
go
gonna say,
ahead.
do you mind if I go back to something that Dr. Jackson brought up about choice? Because I don't want to absolve the choice thing issue because there is a voluntary lifestyle choice component to addiction. Well, it's not all choice, it's not all disease. Sometimes people call it a disease of choice, but lifestyle choice, lifestyle behaviors actually matter, right? So addiction, just like those other diseases I talked about, hypertension, heart disease, diabetes, especially type 2, also are behavioral and have a lifestyle component, just as addiction does, right? And heart disease, diabetes, chronic pain, lung cancer, we talk about diet, exercise, smoking, adherence. Those are voluntary behaviors, but they're heavily shaped by biology, environment, stress, and habit. And trauma and mental health also affects that early choice that the teen may have towards moving into addiction. So sometimes it's not just all choice, but there's definitely a voluntary component involved, right? So addiction is very similar. Substance use choices do matter, and but they're not happening in the context of, but they're happening more in the context of brain changes, stress biology, learned patterns, and understandably, the brain disease model doesn't erase responsibility. I always like to kind of, when I talk about it being the disease, I don't like to give a free pass and erase responsibility, but it reframes it so that we can move from that moral judgment to science informed, public health oriented prevention and treatment. So just like with type 2 diabetes, right? I actually have it. And I can honestly say I chose it. I chose a lifestyle that led me, eating patterns, exercise patterns, probably a family history of it, that led me to develop type 2 diabetes. So, in a simplistic form, I chose type 2 diabetes. It was a choice. Now, it was involved by all those things I mentioned, but just because it was a choice or a voluntary lifestyle doesn't make it any less of a disease. Absolutely not. And I'll say that about addiction as well.
Yeah, and I like what you said too. That a lot of this stuff, is a choice, lifestyle choice, and the rest. But what we pound the table on with family members and also with the person who's suffering is, like, you're not a bad person trying to become a good person. All right, you're not well. So, you talk about the disease model. So if you frame it as, you know, you're not well, we want to help get you well, and we want you to stay well, it's a lot more palatable to them. And now, when people come in, we quit using the word alcoholic. We go, you have an alcohol use disorder. People go, oh yeah, I get that. I get that, but I don't want to be an alcoholic. Or, instead of you're a drug addict, you have a substance use disorder. I
Yeah,
mean, it's not
yeah,
hard. It's not hard to agree with that,
right. I
right?
always say you're not responsible for your disease, but you're responsible for your recovery.
Correct.
Exactly.
And I also say that, addiction is hereditary to a certain degree, but so is recovery. I like to know if they have family members in recovery. It shows that brain may be more resilient as well. So I think addiction is hereditary, but so is recovery.
I
Yeah.
like that. That's a good one. I'll use that one for sure. But it's
But
true. I mean, it's an interesting process, and I think we all love it. I mean, obviously, we're talking today, and we're all very passionate about what we see and what we do. But boy, I can't tell you how much I appreciate you taking so much of your time today to be able to share with us your thoughts about addiction and how much you obviously can teach people within your recovery system. And it's a pleasure to work with you for sure.
yeah, and
Well,
it's a
thank you.
reflection, I believe, on recovery keys and why, we kind of collaborate, with you guys, um, because it isn't a one size fits all. And obviously, the people there are very knowledgeable about the disease, from top to bottom. And the patient comes first, and you look at the facilities, and the message I get when I walk in there is that you're valued, as a person. You're not going into some crappy place, which a lot of people will use as an excuse, like, I'm not going to rehab, I'm not going to this place over here or whatever. But I mean, the great news is, whether it's 3 years, 5 years, 10 years, 20 years of recovery that people have. I mean, that's the beautiful thing. That's why we're in it. When we see people change their lives. I mean, obviously Di and I have changed our lives, and you have too, Dr. Hunt. And it's just a beautiful way to live, and that's where we get a lot of satisfaction. It's better than a paycheck, just to see people like, hey, meet my wife. I got a new job. I bought a house. What,
And
stuff like that.
I always tell people too, or tell my patients, nobody's ever quit using substances or drinking alcohol because of consequences, or at least
Right.
stayed stop, because they quit because their life gets so much better in recovery. There's no need to go back. Brain heals. It's not a struggle to stay sober. I always say, I've never met somebody 3 years in sobriety and go, damn, I wish I hadn't got sober. I haven't met that person yet, right? But
Right.
I know we're running out of time, and I'd like to close with one thing, if I could. I'd like to. This has been a great talk, and I appreciate y'all having me on. But we're the generation that understands addiction at a brain level better than any generation before us. The question is, will we use that science to justify compassion or to build more sophisticated ways to judge and exclude? We do not get to control who carries the genes, who has the trauma, or whose brain gets hijacked, but we do have the control and they have the choice and the ability to control whether we carry Narcan, whether we offer treatment early, whether we speak of people in recovery as survivors, and whether our clinics, our communities, we kill stigma or stigma dies on our watch. And my hope is that years from now, it sounds just as absurd to shame someone with addiction as it did 100 years ago when we used to shame people with cancer, right? Because we know the science, and I hope we choose together to let knowledge make us more human, not less. And that's really what this disease is about, this addiction is about treatment's about, is treating these patients as human beings, without a doubt.
I love
Absolutely.
it.
And
It's the
that's a good
same
quote.
philosophy we have as well. Hey, before we leave, you have written a book. Tell us about it and where people can get it.
Well, it's funny. I've done a lot of lectures, and I did a lot of lectures at UF and different places, and even travel on, and especially in treatment centers, on the science of addiction. And kind of the book, after that lecture, more than any other, if I gave it to patients, they would come up and say, please share this with my family. Or if I gave it at a family workshop, they'd say, oh, I see my son or my daughter so much different. Have they seen this? So a buddy of mine, we wrote this book for patients and families to address addiction as a disease and explain it in layman's terms for patients and families to understand what's going on in their loved one's mind, in their brain, and also to address the stigma. So the book is entitled Understanding Addiction, No Science, KNOW Science, NO Stigma. So it's our platform to kind of, like I said, help us stomp out and kill stigma. And we can if we choose to.
And that's wonderful. And it's a great book. I've read it. It is a great way of explaining things that most people can understand. And you can find it on Amazon, I think you said. So
And it's
I
also,
would
did you
encourage
say,
people.
available on Kindle as well?
I think on Amazon you can download it free to your Kindle from Amazon.
Okay, good.
Beautiful.
And you said
Beautiful.
you were going to sign my book, so I got a pet peeve with you, but
No,
I'll
I'm
be
going to
back.
sign it. I thought I was coming to your thing. I was going to I want to write something so good to you guys, and I actually I have done that. And when you come, I'm going to give it to you, and you can give yours on to somebody else.
Okay.
It's
Anyway,
awesome.
so this is Healing Families Shattered by Addiction. Thank you so much, Dr. Hunt, for being on with us. You can go to our website at familyandaddictionexperts.com. There's a family survival kit on there, which is free for you to download. Information, articles I've written, Di's written, articles we've taken from somewhere else. There's also a link to Recovery Keys, and please watch the video that's there in addition to checking out, all the staff and everything that is available to your family members should they decide to go there. You can send us questions at info@Family and Addiction Experts. We will get back to you, or you might have a question for Dr. Hunt and we'll pass that on to him, and he can get an answer to you. Also, there's a place on there if you want to click for a free consult. Di and I will get you on the calendar and we'll spend 30 minutes or so with you and see if, what's going on specifically with your family, because the dynamics of every family is different. And we'll let you know whether or not we can, whether we're the right fit for you.
Enjoyed it.
All right.
It was great. Thank you so
I
much
will
for
see
joining
you
us.
soon, I am sure.
Yes, we love working with you guys. We'll
Okay.
talk to you soon.
See ya.
Back at you. All right. Take care.
Bye-bye.
Thanks so much for joining our podcast, Healing Families Shattered by Addiction. We'll be back in a couple weeks with more important tools, techniques, and ways for you to focus on you instead of the alcoholic or addict in your world.
Until then, please go to our website, familyandaddictionexperts.com. That's familyandaddictionexperts.com. You'll also see links to our Facebook and Instagram pages. Please also, if you have any emails that you would like to send us, that's info@familyandaddictionexperts.com. That's info@familyandaddictionexperts.com. With any thoughts, feelings, questions that you may have for us, we would love to hear from you, and we look forward to seeing you in a couple of weeks.
Unlock the keys to your recovery today. Visit recoverykeys.org or call 904-551-1394.